Okay, everyone, let's start with hyper and hypoparathyroid disorder now. So in parathyroidism, probably one of the most important things I need to impress upon you is the relationship between serum calcium and parathyroid hormone. Remember that when parathyroid hormone increases, so does serum calcium. So with that in mind, let's just take a quick look here at the physiology behind parathyroid hormone in its normal function. So if somebody has increased parathyroid hormone or it's released, then what happens? Then there are three main players we need to know: that the gut increases its absorption, that the bone increases resorption, okay, so we take calcium out of the bone, and that the kidney retains calcium if we increase our parathyroid hormone. This means that if we have hypoparathyroidism, we're having decreased calcium absorption, we're keeping the calcium in the bone, and we're letting the calcium go in the urine, which means that, again, decreased serum parathyroid hormone means decreased serum calcium. There are many causes. The main cause remains surgical removal and trauma, and surgical removal is much less common now, as thyroidectomy used to always include almost definitely a parathyroidectomy, and now almost never includes a parathyroidectomy as well. There are other causes, including radiation to the neck, genetic factors, chronic hypomagnesemia as well. And we have, again, this set of somewhat non-specific findings that may occur with hypoparathyroidism and really mostly are symptoms of hypocalcemia itself: paresthesia, cramping, fasciculation, fatigue, patchy hair loss, dry skin, brittle nails, anxiety, and headache. And I do want to take a moment here to just point out, as I did in hypothyroidism, why are these non-specific findings things you cannot necessarily use to take home your message? Because if I told you fatigue, patchy hair loss, dry skin, brittle nails, you might think hypothyroidism, correct? So be careful. But these can all occur in a hypocalcemic state. We need to know that if we do have hypocalcemia from any cause, we can have these two signs, Trousseau's and Chopsticks. In Trousseau's, you'll have carpal pedal spasm, so either carpal or pedal if the blood pressure cuff is on the arm, or of course the leg. And if you inflate it to a greater than systolic for more than 3 minutes, you'll have spasm below. Chopsticks means that on the same side of the face, if you tap anterior to the ear, you'll have contraction. And this also means hypocalcemia. If people have prolonged hypoparathyroidism and subsequently prolonged hypocalcemia, they may have significant issues: seizure, renal calculi, papilledema, psychosis, Parkinsonian neurological issues, as well as cataracts. That's very prolonged. Renal calculi themselves have a very specific place because I think a lot of times academically people tend to associate renal calculi with hyperparathyroidism, but it occurs in both. So remember on a test question that it could be either. In hypoparathyroidism, it occurs because, as I mentioned, the kidney is letting calcium go in order to decrease serum calcium. Now, obviously, if they gave you lab values, the parathyroid hormone would be decreased by definition in hypoparathyroidism, but the calcium would also be decreased as well, as I mentioned. Remember that magnesium and calcium tend to go together, so if calcium is decreased, mag should be as well, and phosphorus always goes the other way, so the phosphorus will be increased. In order to treat this, we use oral calcium and vitamin D to keep the serum calcium at a goal of greater than 8, and magnesium supplementation as well. So remember, with hypoparathyroidism, this is what we're going to look for. Now let's look at hyperparathyroidism and contrast and compare these two in the way that they may or may not present. In hyperparathyroidism, again, now we have too much serum parathyroid. That means too much serum calcium will result, correct? There are either primary or secondary causes of hyperparathyroidism. Primary meaning that the parathyroid glands themselves are making too much hormone. This can be due to local adenoma or hyperplasia, in which case treatment is parathyroidectomy, or malignancy can also be associated, although this is rare. Secondary hyperparathyroidism can be in response to calcium or vitamin D deficiency in the body's attempt to then increase serum calcium levels, or the single most common cause of any hyperparathyroid disorder remains chronic kidney disease and its relationship to chronic hyperparathyroidism. Now, this occurs because your kidneys convert your vitamin D to its available form. And since in chronic kidney disease you don't convert the vitamin D to its active form as much as you should, you therefore actually absorb less calcium without the vitamin D. The subsequent hypocalcemic state causes your body to have a reactive hyperparathyroidism in an attempt to raise calcium levels, and this continues in chronic renal insufficiency. If we have hyperparathyroidism, you remember that the three factors in parathyroidism are what? Gut, bone, and kidney. So I'll have increased calcium absorption. I'll have increased calcium resorption, take it from the bone, and I will, in this case, I will have trouble with the calcium, and I will keep it. I will keep the calcium. So what could we have as symptoms? We can have osteoporosis because we're robbing the bones. And in some patients, if they have renal failure, this is renal osteodysgenesis, but they're similar in the fact that the bones are being robbed of their calcium. You can have renal calculi, which I will explain. Bone pain, GI symptoms, distress, depression, fatigue. This is where we get this paradigm of bones, stones, abdominal moans, psychiatric overtones, etc. Serum-wise, we're going to see an increased parathyroid hormone, an increased calcium, a decreased phosphorus. Okay? And I want you to remember that although from a endocrinology standpoint, we really should have decreased urine calcium, and therefore we should not get kidney stones. We do get kidney stones in hyperparathyroid states in their prolonged state because although initially you have low serum calcium, over time Christian, you have to stop that last part. Okay, so start where I said initially you have low serum calcium. All right, cut that part out and start right here. Although initially you have low urine calcium, over time, because the serum calcium is increasing over time more and more and more, it at some point overwhelms the kidney's ability, and therefore the calcium starts to spill into the urine. In addition, I want you to remember that we may need to treat the osteoporosis, or in some cases renal dysgenesis, and these are some of the treatments, but those will be covered in the rheumatology section. Far as treatment goes for Christian, cut the part where I said far, and let's start again. As far as treatment for hyperparathyroidism, if it's primary, as I mentioned, surgical removal is the answer. If it's secondary, the most common being chronic kidney disease, these two medications, Insulet and paracalcitrol, remain the most common medications to help control the hypercalcemia that will ensue.